SRS or stereotactic radiosurgery defined as treatment delivery to the brain or spine, and generally speaking, SBRT is extracranial, so things that are elsewhere in the body, in the human body. So let's go to the next slide. Yeah, it's really slow for some reason. Not sure what's happening here. Okay, there we go. It's probably because there's so much bandwidth on so many, let me see if I turn my video off, and that might help.
Okay.
Yeah, there we go. Maybe. Yeah, it seems like my animations are not working, or they're very slow to update. Yeah, I mean, I've got a frozen screen now. Okay, there we go. So just to kind of go through utilization of SBRT, this is growing at a huge pace, so it's almost exponential here. And this is a dated slide from 2010, but it kind of shows the trends for utilization of SRS SBRT. There was a survey that was done, that was published, 1,600 radiation oncologists were selected. They got 500 responses, and this is what they saw in terms of utilization. So as of 2010, we're about 65% of physicians were prescribing SBRT. And if you look at the breakdown, so every time I try to go to the next slide, it's just taking forever. I'm not sure the reason for that. Let me try this. Yeah, if I do it this way, I'm going to lose the animations though. Maybe.
Okay.
Let's try this. Okay.
Okay, great. So,
okay. So is that next slide? Do you see that?
I see it perfectly.
Okay, perfect. Okay, let's keep going and see if it works.
Great.
So the most common treatment sites are lung 90%, spines about 70%, liver 55%, and others was less than 10%. But if you look today, especially with technologies like MR guided radiation, the number of these sites, pancreas, adrenal, prostate, and retroperitoneum, has really increased. So, this utilization's gone up quite a bit. So I'd say overall now we're more probably, if you follow that exponential chart, 80 to 90% of sites are now hypofractionated. And a lot of them are SBRT, small number of fractions. So why do we worry about SRS and SBRT? Well, it has to do with complexity. And these are very complex procedures that are difficult to work with. And you have these complex interactions between different factors that confounds the ability to image and target accurately. You have small number of fractions, so these setup uncertainties cannot be averaged out, as with conventional treatment. High dose per fraction means you must hit the target and avoid the normal tissues. And then small fields, 3 cm down to even 5 or 4 millimeters. And as you will see in this presentation, the physics of SBRT is quite complicated. All of this means that the beam model, target definition, dose calculation, and target localization must be highly accurate. You have to get it right. You have 5 fractions or less, and so there's no opportunity to average out uncertainties. So why is this important? Well, when you make a mistake with small field dosimetry, it can result in real consequences to the patient. And so I'm going to give you a couple examples now of accidents that have occurred. One, this was published in France in radiation protection dosimetry. This was 145 patients treated in 2006, 2007 for brain tumors using a 6 MV beam with a micro MLC. The error was due to the inaccurate small field output factor measurements. And it turns out that they measured these output factors with a Farmer type chamber with an air cavity of 0.65 cc, internal diameter of 6 millimeters, and length of 23 millimeters. So I'm hoping that many of you are shaking your heads and saying that you would never measure small field output factors with a large ion chamber. So the issue is that the Farmer chamber suffers from volume averaging effects due to the large size, and it significantly underestimates the output factor. This led to an overestimation of the monitor units of up to 200% factor of 2. And you see that here now. So the this upper curve with the circles is how these output factors should have been measured, right? It should have been measured with a pinpoint, 0.03 cc's. Instead, it was measured with the triangles. You can see the difference. So if you come down to, let's say, 1 centimeter, 10 millimeter, you're off by a factor of 2 over 2, about 2.5. So that's why the overdoses were scaling directly inversely with the monitor units, right? So, and resulting in overdoses to the patient. So clearly you can see the big effect of volume averaging here. Well, this certainly occurs in other countries. Has happened in the United States. In Missouri, 2009, there were 76 patients that were impacted, undergoing SRS overdose by 50% due to miscalibration of the equipment. What they found was that they couldn't really find the error, but I think the error was related to an incorrect volume ion chamber to measure the small field output factor. So the same issue that you're facing with using a large detector. This has occurred multiple times, and my hope is that we learn from these kinds of mistakes. So the other problem is that it's very difficult to measure these output factors. It's quite challenging. So it was a survey of 40 identical SRS Linux, and they were asked to do measurement of a 6 by 6 millimeter MLC field. And here's the variation. So the physicists had the same machine. They were asked to do the same measurement. And there's a variation of 45% in this measurement. And you might think that we can do this with more certainty, but these small field output factors are quite complicated. They're influenced by small setup uncertainties as well, in addition to variations in the type of detector you use. So this is troubling because this 45% scales directly with dose and monitor units, right? So if you are different by 45%, you're going to have monitor units that are 45%. In some cases, for these low output factors, high by 45, 50%. Okay, so let's talk about the physics of small field dosimetry. Lots of great articles. Small fields, non-equilibrium radiation dosimetry was published. This is now the AAPM Task Group 155 that's been published, but we also have the IPEM report on small field dosimetry from the Institute of Physics and Engineering Medicine in the UK. And there's also the TRS IAEA reports, 483, which is a very helpful document. So what is considered a small field? The IAEA number 483 says the following: at least one of the 3 physical conditions will be fulfilled for an external photon beam to be designed small. First, there's a loss of lateral charge CPE. Second, there's a partial occlusion of the primary photon source by the collimating devices. And third, the size of the detector is similar or large compared to the beam dimensions. So if any one of these conditions are met, then you're often dealing with small field. And back of the envelope type of thing, you can say you're generally in the small field region when you're less than 3 centimeters. So let's talk about what the occlusion of the photon source means. So here's a picture from one of these publications. If you look at the location of the phantom and you're looking up, in this particular case, you see that you're encompassing the entire source, right? This is a larger field on the left. On the right, you see in the small field setting, if you look up from the region of the phantom up, you see you're only encompassing some fraction of the source. You're missing the edges of the source. And when you think of the output of the machine as being defined as the sum of fluence over the full source, if you're only seeing part of the source, you're only going to see part of the fluence, right? And as a result, you see this under region of lower dose here that is not properly accounted for in planning systems. So when you get very small, you don't account for this eclipsing of the source, which can be quite problematic. So there's my colleague in the UK did some Monte Carlo simulations. Got another message on my screen here, or something on my screen. Okay.
So,
are we back?
Yes, put it back, please. We kindly ask the participants not to start sharing their screen.
Yeah, I think that's what's happening. That's what's causing this.
Yes, so we really kindly ask you to be careful and not start sharing your screen. Thank you so much, and I'm sorry for the inconvenience to all of you. But Dr. Chetty, please keep going with your
Okay.
excellent presentation.
Thank you. I'm going to get back to presentation mode here. It looks like I lost control of my screen again. Yeah.
So I
Okay.
see your screen fine. I just see it on a slideshow. Yes.
Yeah, I'm trying to do this slideshow. I lost control of my screen again. Sorry.
It's okay. So while you have your control again, I
There,
think
okay, there we go. We should be back now.
okay, great. It works fine.
Right. So my colleagues in the UK did some Monte Carlo simulations, and in specifically they looked at simulating the treatment head of the machine. In one simulation, they just did a point source, and in the other simulation, they did a full geometry, meaning the full size of the source, which is typically a Gaussian distribution. And what you see is that the output factors track for the point source. You get down to about 0.9 for the output factor when you're at a small, very small field, about 2 to 3 millimeters. But for the full geometry, using the actual source of the linear accelerator treatment head, you see that you drop significantly as you get less than about 7 millimeters or so. And this is resulting from the occlusion of the point source. And so, but what they did to do this calculation is they scored the karma. So you look at photons only. So you're not dealing with any lateral electron transport issues here. It's just because of the occlusion of the photon source. Okay, so how do the current planning systems manage this? Well, depending on which treatment planning system you have, we have Eclipse, and we did some simulations with the small field beam model in Eclipse. We looked at a 0.5 by 0.5 cm, and we did Monte Carlo calculations as well. And if you look at the AAA algorithm, these are the default settings in AAA. If you're at 0 millimeters versus 1 versus 2 versus 3, you see how the output factor varies. And the Monte Carlo is showing an output factor between 1 and 2 millimeter, which is correct because we know the source is about 1.5 millimeters, right? And you see the same kind of behavior for the Acuros algorithm. If you look at the defaults of 0, 1, 2, or 3 millimeters, you see the variation in the output factor here versus the Monte Carlo. All right, so we're going to get to a question now. So I'm going to let Maria help me with this. And the first question.
Yes, great. So I'm going to launch the simple question, but if you want to go ahead and read the question, Dr. Chetty.
Okay, great. When the field size is less than 1 by 1 centimeter squared, A, lateral photon scattering decreases. B, lateral electron scattering decreases. C, beam energy decreases. And D, effective photon source becomes occluded.
Okay, so I've launched the simple. So far, only like 30% of the participants have answered. So you go ahead and put your answers to Dr. Chetty's question. So we will give a few more seconds and I will share the results. Okay, almost half of the participants have answered the question. So if you want, I think they can share. Okay, so can you see the results on the screen?
Yeah. Are we done with the poll? Okay, great. So good news, 43% got it right. The answer is D. The photon source becomes occluded. Effective photon source becomes occluded. And we show this here. I talked about the fact that as you get down to very small fields, you're occluding the ability to see the source. Now, let's look at the other options. Lateral photon scattering or lateral electron scattering doesn't decrease or increase. This depends on the type of medium, right? If you're dealing with one type of medium, it's an irrelevant thing. So it's not really relevant to this. If you're dealing with a medium less dense or more dense than water, that's where the lateral photon scattering either increase or decrease. And then C is beam energy decreases. Actually, beam energy increases slightly, so that's not true.
Okay.
So D is the answer, and you see that. Okay, so we go next slide. So do I need to exit from here, Maria, or I'm good?
Exactly.
Okay, great,
Yes.
perfect. Someone close this. All right, so let's look at typical beam arrangements for treatment planning. There's some considerations in this regard as well. So I'm just showing some examples here of 7 non-coplanar beams for a lung lesion. It's a chest wall lesion. You always want to choose the beams with best geometry. For instance, you want to avoid beams going through contralateral lung. You want to reduce the amount of lung. If you're in the lung area, you want to reduce the amount of path length that you go through lung. You want to use non-overlapping beams, non-coplanar beams, so on. Here's an example of a 7-field liver. Again, you see you want to keep it, sidedness is important. Keep your beams to one side of the patient. 7-field lung, 8-field pancreas. Using common sense in the planning process to avoid normal tissues is an important thing as well here. It's very important to use lots of beams. The examples I showed you are using many beams, right? And the reason for that is if you use too few beams, you can end up with very high skin dose. And this is a picture from a publication in the Red Journal back in 2008 of a patient that got a very, very bad skin reaction because they were only using, I think, 2 beams in this type of treatment with high dose. So you have to spread out the skin dose, and that's why you want to use a lot of beams. Okay, so another very important point with SBRT planning is that you want to use a small or no block margin. In a conventional plan, you have a block margin, right? And the block margin accounts for fall off beam penumbra, right?
Yeah.
And your maximum dose is generally within 10%. You want to keep your homogeneity within about 10% in a conventional plan. In a radiosurgery SBRT plan, you want to use very small margin, block margin or 0 to 2 millimeters, very small block margin, or even less than, even smaller than that in a negative block margin, because you want the dose to be pushed up. When you use a very small block margin, you get a very high heterogeneity in the dose distribution, up to 25% or maybe even more, depending on where you prescribe dose. So block margin needs to be small. What about dose requirements and target dose and the normal tissue doses? There are lots of documents. The RTOG or NRG 0813 trial and 0915 trial provide some nice dose information. One of the things about prescription dose is they want it to be greater than 60% and less than 90% of the maximum dose, because you really want that hotspot to be driven up. And then there's other information here that's provided about high dose spillage and normal organ doses. So here's an example of the normal organ doses from RTOG 0813, 0915, and APM task group 101 for different organs. And you can kind of see here and use this as a recipe or as a safety document to ensure that you're protecting the normal tissues when you're doing this type of procedure. There's some terms that are used: dose conformity, the RTO definition being conformity index ratio of prescription isodose to the planning target volume. Generally, if the PIV is too large, you're over-treating normal tissues. If it's less than 1, it's too small and you're potentially under-treating the tumor. And then some constraints for spine SRS from RTOG 0631. Which was Dr. Yu when he was at our institution. He was the PI. And with this type of fractionation, he was talking about 1 to 3 fractions here. You have constraints on your spinal cord. You want that maximum dose 0.35 cc's to be less than 10 gray. And 10%, this 10% versus 10 gray information is helpful. Less than 10% of the spinal cord to get less than 10 gray. And other criteria as well here.
Dr. Chetty, sorry to interrupt you, but I have a question for you for the Zoom chat. So,
Yeah.
there's one document, and I think that Robert Timmerman and everybody agrees that has a great experience in SBRT, and he has published his list of constraints, which he has a very nice publication from the Red Journal, like two
Right.
years ago, I believe so.
Yeah.
So we
Mhm.
wanted to know, one of the participants wanted to know if you ever use the famous Timmerman tables for planning evaluation for the constraints.
Yeah, it's a great point, and we are very familiar with that. In fact, we just put out the Astro Blue Ribbon panels constraints for the VA panel that I was on. And we did look at Timmerman's paper, so we're familiar. It's kind of, different institutions have different thoughts about it. We don't specifically use Dr. Timmerman's constraints. We use the TEG 101 and the 0915 constraints, but they're very similar, right? Like if you look and compare, they're pretty similar for different types of fractionation regimens. I think Timmerman does it. I think he gives different fractionations also in his paper. I think it's a very good resource. It's an excellent resource. He has great experience with it, and he's really an expert in that area.
Okay.
Yeah. Great question.
And I think we can share to the participants both the Timmerman paper and the ones that you use. Thank you.
Sure. So in terms of physics, let's talk a little bit about what happens in small field dosimetry. One of the issues that you're encountered with is this lack of charge particle equilibrium, or lateral charge particle equilibrium. Here's the case for a broad photon field. Number of electrons, in this case, leaving this volume is compensated by a number entering the volume. So you have a steady state or a condition of equilibrium. But in the narrow field, though, you see what happens is that more energy leaves than enters because you have a lack of lateral side scattering here, right? Because it's a small field, you don't have other electrons that can contribute to electrons that are leaving the volume. So what happens is in a narrow field, you have loss of charge particle equilibrium, and the dose reduction can be severe. Now, if you're dealing with lung cancer, it's even more problematic now, because what we're looking at here is scattering of electrons in low density lung tissue, where the dose is carried away from the tumor. So this really should be lung equivalent. It's not air, it's water, lung, and then water. And then this was a Monte Carlo simulation done with a pencil beam on this interface or on the central axis. So you can see the tracks. So what you're looking at here is electron tracks. Density is 1 in water, it's 0.2 in the lung, and then 1 in the water again. And you can see how the electrons carry dose away from the central axis because the range increases inside the low density lung tissue, right? So if you had, there's a bit of a mistake with this picture here, because what it should have been is something like this. I'm just going to correct this on the fly here for you. Let's get back here. So now you have this tumor on the central axis, and if this were unit density, you would see the tracks, it would deposit dose inside the tumor, but because you have scattering now inside the lung, you're carrying dose away from the tumor. So what happens is that you end up with a very significant issue here, and let's see if I can get the animation to work again. Okay. So what I'm showing here is a depth dose curve that we actually measured and we computed with Monte Carlo. We measured with ion chamber. This was a small field, 2 by 2 cm, and it was again the slab phantom. Density of 1 here, density of 0.2, and density of 1. And you can see what happens inside the phantom, inside the low density region. You have this significant loss reduction of the dose, right? Because of the issues I just shared. You have loss of charge particle equilibrium, and you have lateral scattering, where the electrons increase the lateral scattering range because of the low density. And then you have this rebuild up of dose, because now when you get back onto the higher density side, you start stopping these electrons. And when you slow down the electrons, they deposit dose over their range. Now, if you looked at this in the context of a 2D setup, here's a 2D version of this. You see, this is the tumor inside the low density lung. Here's the range up to this region of the electron. So you have this build up, rebuild up of dose, which corresponds. So this ring corresponds to this region on the depth dose curve. And as the tumor gets smaller, the range stays the same, but the volume of the build-up region now becomes larger relative to the volume of the tumor. And then as you get down to very small tumors, now in the forward direction, you don't even stop the electrons. And so your reduction of dose can be severe. It means that the dose calculation algorithm has to be quite accurate. Okay, there's also an energy effect. So here's the range for a 6x beam, let's say. And then as you go to 15x, you see the range gets more, right? It gets twice, or, well, in this case, you could see this arrow should be, the second arrow is a little bit off, but this arrow showing the full range here increases with 15x, right? Because of the range. The higher energy means higher range of the electron. This is one reason that you want to avoid using high energy for lung tumors.
One question.
Right, so here's the,
I'm sorry, Dr. Chetty, one question we have on the chat, and I think it goes perfectly with what you showed from the energy in the previous slide, is how often do you use an energy of 10 microvolts for SRS and SBRT? Yeah, so we typically use 6 for most of our SBRT lung, especially small lung tumors. I would say for SBRT, it's mostly 6. For larger tumors where you're dealing with locally advanced lung cancer, then I think it's we can go to 10 or even 15 sometimes, depending on the habitus of the patient. If there's a larger separation, you should the larger energy helps. But for SBRT, we're typically using 6x. Okay, great, thank you. Sure. So here's an example of in a planning system that we actually have. Limitations of the pencil beam algorithm. So this is a small tumor, about 3 centimeter diameter, 15 cc in volume. If you plan this with the pencil beam algorithm, you see the coverage here. Here's the PTV, and you get very nice coverage of the 95% line. Now, if you plan this with the same planning system, but switch to the Monte Carlo algorithm, you see a significant underdosage. Right, so now your 80% line is barely even covering your actual GTV, which is problematic. If you look at the DVH, you see significant difference here between the Monte Carlo and the pencil beam. And this sort of gradient in the distribution here is due to this ring effect that I talked about. Right, there's a rebuild up of dose at the edge of the tumor, so the edge of the tumor gets significantly underdosed relative to pencil beam. And here's the normal lung. The Monte Carlo predicts greater low dose spread in the normal lung. Makes sense because the Monte Carlo is predicting correctly the lateral electron transport. The energy effect showing the distribution for a 6 MV pencil beam on the top and the AAA on the bottom. And you can see this bottleneck effect. Again, AAA is accounting for the spread of lateral energy away, right? These electrons are going to take off inside the lung. And so as a result, the dose is getting reduced here. And then if you look at 18x, how much worse this effect is now. On the top, you're looking at the pencil beam distribution. And on the bottom, you see a much, much bigger effect with high X beam, right? Where the 95% line is being is now not even close to covering the PTV, even the 90% line. So this is more of a 10-15% effect versus maybe a 5% effect with 6x. So we published this paper back in 2013 where we looked at about 150 patients. This was in the Green Journal. And we showed in general that when you're dealing with pencil beam algorithms, whether it's 1D or 3D, it doesn't work very well. You can see it's overestimating coverage. But when you look at other algorithms,
This was Monte Carlo, collapsed cone convolution, AAA, and Acuros was included in here. They were all about the same. So the good news is that the convolution superposition algorithms or Acuros or Monte Carlo are generally giving roughly equivalent results. And if you look at this, I magnified the scale here just to show you this goes from 36 to 48. So we typically do 12 times 4, right? And if you did 12 times 4, you see either pencil beam algorithm works well, gives you right results, but all these other algorithms, including the Monte Carlo, collapsed cone, Acuros, are showing significant difference under dosage. And they're about the same. There's some maybe slight differences here or there, but generally it's within 2 to 3% on average. Okay, second question. So tell me when I can start reading.
Second question. So you can go ahead and read it, and then I'll launch the question.
Okay, great. So along the central axis for a 2x2 cm 6 MV field in a water lung water phantom. So we have 4 centimeters water, 6 cm long, and then followed by 10 cm water. The dose in the lung portion will A, increase because the density of the lung tissue is higher than that of water. B, increase because of increased photon scattering in the lung tissue. C, decrease because the range of scattered electrons increases in the lung tissue. Or D, decrease because the range of scattered photons increases in the lung tissue. Thanks.
Okay, so answers are coming in. We will give a few more seconds for the participants to put your answers, what you believe is the right answer, and we will go ahead and start the discussion with Dr. Chetty. So almost 60% have answered, so we will just wait a few more seconds to see if more answers come up. And I think, yes, I will end the Zoom poll question. Okay.
Okay.
Results.
Yes, I can. So again, great. 43% got it correct. The answer is C. It'll decrease because of the range of the scattered electrons increases in the lung tissue. So as I've been explaining, because as the density goes down, the lateral range increases. And so that's that. So if we look at the other answers, increase because of density of lung tissue is higher than that of water. Well, that's not correct, right? Density is lower. Increase because of increased photon scattering in the lung tissue. No, actually photon scattering goes down in the lung tissue, whereas electron scattering goes up. And then the last answer was decrease because the range of scattered electrons increases in the lung tissue, and that's not decrease because of range. Oh, I'm sorry. The answer is D. I apologize. I'm just looking at this. The decrease because range of scattered, oh, I'm sorry, scattered photons, scattered electrons increases. C, sorry about that, I'm confusing myself. So it turns out the range of scattered photons increases in the lung tissue. Not very much at all, actually. It's the range of the scattered photon. Remember, it's photons undergoing Compton interaction. So the Compton interaction is dependent on electron density. Electron density is about the same between lung and water. So that's not going to be an issue. So it's really the electron range that increases. All right, we'll move on.
Yes, so you can keep going on your presentation. Yes.
Okay, great. Okay, so we're talking now about some exciting stuff about image guidance. And this is you can see a transformer trying to hit a fly here. But basically that's the idea, right? You want to be able to hit this fly as it's moving around. So there are many technologies that we can use to target accurately, and you can see some pictures of these very nice systems that we have: cone beam CT, MR guided systems, CyberKnife, tomotherapy, and things like that. So treatment mistakes can also occur with these technologies, and this is another example from this paper that I shared earlier in France. This was a mistake with a patient treated with an arteriovenous malformation with an SRS fractionation 6 MV with cone collimator. And it turns out that when they were trying to communicate what the backup collimators have to be set to. So with some systems, and when you start integrating different cone systems with linear accelerators, you have to set up the backup jaws to a certain location. Otherwise, you're going to get leakage radiation, which can be significant. So in this case, the collimator should have been set to 40 by 40 millimeters, right? They're set to 40 by 40 centimeters. You can imagine the issue from that. So here's a nice picture of how this works. Normally, you want the cone assembly to be collimated, right, to the backup jaws, as you can see here on the left. So there's no leakage, right? On the right, when the jaws are very wide relative to this accessory mount, see the leakage radiation, this happens. And that's as a result, this was even published in the New York Times article. You can have a significant impact and patients die as a result of this. So that's kind of why this is very important, is you can have treatment mistakes too, and QA, and safety needs to be key. So here's a picture of the different type of solutions that we have. We have, we typically know as a conventional ITV-based treatment. And then there's a gating treatment where the beam turns on when the tumor is in the gating window. There's a breath hold treatment, right? And then there's a tracking treatment where you're moving the MLC, or the source, with the actual tumor. When you're doing ITV-based treatments, you can have setup uncertainties. And this is an example from a colleague of mine. And you can see what's happening, right? At simulation, you get one circle. At treatment, let's go back. You see, this is your simulation ITV. And then at treatment day, you're seeing something different. This is called a baseline shift. How do you account for it? Well, cone beam CT was a major advancement. It allowed us to see things in three-dimensional space, right? So what we're seeing here is a picture from one of the first papers. And on the left, you can see the two circles, how you're able to see it volumetrically in 3 dimensions, on the axial cut and the sagittal cut here on the right, how you can then make the correction for this type of thing in 3 dimensions. So there have been many, many papers talking about how, if you do daily image guidance, how you can really improve localization in your margins. And we looked at 150 SBRT lung cases. And if you just looked at localization based on the skin tattoo, this is what your planning margin using the Van Herk formalism would be. Okay, so for the different locations of the tumors, so for instance, if you took upper peripheral tumors or lower chest wall tumor, you can kind of see your margins are generally 12 millimeters or above 10 millimeters, right? 8 to 10 millimeters or even higher in the different dimensions here. So the different colors represent the AP, sup, inf, and left-right dimensions. But if you start now then looking at cone beam CT and looking at residual errors, you can see you can significantly reduce your margins. Your planning margins can be reduced to generally around 4 millimeters if you do daily cone beam CT. And there are many papers talking about this kind of thing.
We have a great question about the cone beam CT, so I'm going to do it right now, Dr. Chetty, if you're okay with that. What is your tolerance for movement shifts for your cone beam CT? So if you go ahead and do it, how often do you have to correct? Do you have a tolerance margin for the movements?
Yeah, so it's 2 millimeters for us.
Okay.
We follow the 2 millimeter kind of workflow. 2 millimeters, and then I think it's 3 degrees, 2 or 3 degrees for the rotation. Yeah. Okay. So, we try to keep things consistent with the task group report requirements too. So we generally keep it within 2 to 3 millimeters. I mean, with margins, with planning margins, if for SBRT, you're dealing 5 millimeters, you're dealing with 5 millimeters anyway. And, there's some leverage with that depending on your fractionation. If you're dealing with a CNS case, 2 millimeters, brain, spine, there's definitely 2 millimeters. For lung SBRT, there can be a little bit more judgment there. So maybe, 2 to 5 millimeters, I would say more like, because we know there can be a little bit more uncertainty there. But we generally, for SRS SBRT, within the 2 to 3 millimeter range.
Thank you.
So Go ahead, sorry.
No, thank you.
Oh, sure, yeah. So this is a paper talking about if you did 3D cone beam CT and compared it to 4D cone beam CT, which Varian now has capability. Electra has had it for a while for 4D. And you can see, you know, here's a 3D CBCT and the sagittal and coronal. And then if you look at the 4D cone beam CT and the peaked inhale, you can see the variation relative to the 3D. And then here's the exhale. And you can see the exhale is in better agreement because 70% of the breathing cycle is in the exhale position anyway, right? So some considerations for ITV-based treatment. Volumetric information is available to correct for systematic uncertainties. One is able to view normal tissues, but the imaging information is static, it's not dynamic. One cannot account for real-time motion. You have the ability to see a 4D CT. I'm not sure that you can actually use it for treatment, but you can see it. Treatment imaging of the ITV might result in unwanted dose to the normal tissues. If you have large amount of motion, your ITV is going to be large. And then the alignment of cone beam CT to the reference planning CT may be tricky. So you have to figure out which data set you want to use. Are you using free breathing? Are you using the average CT? 40 cone beam CT might be helpful here. And then you have noise and artifacts, which can confound proper visualization, especially where patient scatter is significant. And you know, artifacts can be problematic, motion artifacts in particular. So there are other approaches that you can use for things like gating, right? We know about the ABC device. You see some pictures of the active breathing control device here. So ABC has been applied to many different sites, including, you know, now for deep inspiration, breath hold for breast, but also for lung and liver tumors. And there's many studies showing short-term reproducibility is good, a few millimeters, but long-term reproducibility can be higher with this. You can have larger shifts, you know, averages were 2 to 3 millimeters, but they're up to 4 millimeters, 9 millimeters, so on in different publications. So have to think about that. And then it increases the treatment time a factor of 3 to 5, because you have to make sure a patient is comfortable, you know, they're following the instructions, and then there's a duty cycle there because you can only treat when the patient's within this, you know, within a certain breathing window, right? This gating window. So that always adds to the treatment time. You can do gating with external surrogates like you see here for the RPM system. And here's you know, a picture of the marker and diaphragm position that's showing tracking fairly well in this case, but there's an offset, there's a phase offset you have to account for. But it doesn't always work this way. You can have a systematic shift, and in this case you can correct it, but you also have you can have very inconsistent correlation between your external marker and your tumor position. And there are studies showing that sometimes the surface marker surrogates can be a poor surrogate of the actual tumor motion because there's poor correlation. So you have to think about that. Other approaches, including implanted fiducial markers. This is a system that came from the RTRT folks, the folks in Hokkaido in Japan. They're using 4 X-ray tubes and intensifiers, and they're getting 30 frames per second. They're getting spatial precision within 1.5 millimeter. But you can have very high skin dose here because you're essentially imaging in a fluoroscopic way during treatment. So you have to watch out for skin dose. There's the ExactTrap brain lab system that you all know about now. It's these optical guidance system with infrared cameras, and it's stereoscopic, trying to stereoscopically identify using planar X-rays, using surrogate bone surrogates. But here's a picture of how this can work for gating. On the left, you can see the large tumor motion. And on the right, what you're seeing is that the radiation is turning on when the tumor is within the gating window. If it turns off when it's outside the gating window. Other systems like the CyberKnife, which is a 6MV LINAC, you have a model that you're using to correlate tumor motion, but this is limited to beams in the AP hemisphere. You can't use PA beams in CyberKnife. And then there's a tracking system that has been developed in conjunction with Calypso. If you implant the Calypso transponders, you can use a connection between the MLCs and the signal that you get from Calypso to actually track the tumor. So you actually have dynamic MLC collimator motion here. Other Linac-based technologies, you see a couple examples from the two major vendors, Varian, the Varian Edge system, and on the right, the Versa system from Elekta. They're all pretty similar in the technology. It's onboard cone beam CT, 4D cone beam CT, real-time MV EPID, high definition MLCs. You have triggered imaging that you can do to help you if you have internal surrogates. You have also, you can tie this in with surface-based tracking. Of course, implanted marker tracking and, are another approach. And then there's real-time ultrasound tracking as well, which I'll kind of talk about. So here's the surface-based tracking with the Align RT system. Essentially, you're defining a region of interest and you're tracking it, and you can gate to the radiation beam using this system. You can see sort of the surrogate motion of the patient chest here. And you can set your default parameters for beam off. So 2 to 3 millimeters might be reasonable for a SBRT treatment. And then there's ultrasound technology as well. I'm not sure if this is actually commercial. This came from Elekta, where the ultrasound actually is moving in conjunction with the motion of the prostate. All right, so with regard to respiratory gating and tracking, it can reduce normal tissue exposure, especially for tumors moving with large amplitudes. Gating increases the time considerably, 2 to 5 times based on the percent duty cycle and patient compliance. So you have to think about how long the patient's on the table. Implanting fiducials can be invasive. With gating, residual motion behaves unpredictably and could exceed planning margins. So the daily imaging guidance should be performed using 3-dimensional techniques as well, because you can have motion that's quite erratic relative to surface motion in some cases.
Okay, so now that you have that slide, I'm going to go ahead and ask some questions, because some people have asked in the chat if you have a preparation for any of this. So if you will go with the gating, or you would go and prefer the exact tract. So two persons kind of ask you what you believe could be the best for this kind of treatment. Yeah,
and the way that you do that is you look at your own data, right? So we have a 6-hospital department. One of our departments has an exact track system with cone beam CT on a Novalis TX machine, and other systems have the edge, like where it's just a Varian Edge that we're using without the exact track. We've looked at our own data. We've actually published our own data, and what we found is that it's very similar. So the imaging that you get so if you do multiple cone beam CTs, let's say, and compare multiple cone beam CTs to the initial cone beam CT and then the exact track images, that the uncertainties between the two we found is within about millimeter and a half. So as a result of that, we feel that we can use either technology. So if we're doing brain treatments on the Varian Edge, we don't have exact track. We line up to the patient tattoos. We do cone beam CT imaging, and then we do, prior to beam on, we do a KV-MV verification image to make sure that there's no shift in the isocenter, and we have a 2 millimeter threshold for that. So that workflow works very well relative to the workflow on our Novalis TX, where you're still doing cone beam CT, but you're doing exact track images. Okay. So roughly about the same within a millimeter. Okay, great. Thank you. Yeah. Sure. So I was talking about this correlation between the internal motion and the external patient motion. So the surface versus the tumor, and in the top one you see again correlates well, but then it's sort of a broken correlation at some point. And in this second view here, the AP view, external fiducial versus the internal superior motion, you can see very poor correlation between the external marker and the internal surrogate. So you have to worry about this for gating. Yeah, I see a streak on my screen. I'm not sure what that's about. Sorry. All right, so this is an example in which we looked at planning CT and then cone beam CT. This is an example from David Jaffrey he sent me when he was at Princess Margaret, just to show the importance of looking at all of the anatomy in 3D. And so on the left, the planning CT, on the right, the high dose region and PTV, and there's you have the heart set up here. And you can see that you're doing relatively well. You're separating from the heart on the central axis. And you keep looking through this and you'll see at some point the heart starts overlapping. And so you can see the heart's overlapping the high dose region at a different location in the same CT, volumetric CT study. So using this information, they were able to shift further away from the heart. Okay, so it's important to look at the full 3D geometry of the anatomy. What it means is that the targeted normal tissues don't necessarily move together, and that seeing the normal tissues may be as important as seeing the target because you want to avoid the normal tissues. All right, third question. Which of the following statements concerning image-guided treatment delivery is false? A, the treatment time for radiation delivery of a gated treatment is generally higher than that of a free breathing treatment. Remember, the answer is give the false one, right? B, surface-based image guidance may sometimes be a poor surrogate for tumor motion. C, patient alignment using volumetric imaging may help reduce treatment margins. D, it is important that the strength of the imaging surrogate be considered in the planning margin design. Or E, daily imaging using planar X-rays gives excellent information on the motion of tumor and normal tissues.
Okay, so now you have the simple,
Yep.
the simple question. Great. Okay, so remember is the false answer.
Right.
So almost 30% of the participants have answered. So a few more seconds and we will close the simple question to see the answers. Okay, so I will share the screen.
Okay.
Okay, can you see it, Dr. Chetty?
Yes, I can.
Okay, great.
So excellent. So most of you got the answer right, which the answer is E, right? That's the false answer because daily imaging using planar X-rays can't tell you about motion, right? I mean, you know, if you want to do really a full study to look at motion, you want to do a 4D cone beam CT or volumetric study, right? But certainly not with X-rays. And it turns out all the other answers I think are straightforward, where all the other answers were true, right? And only this answer E was false. So we will get back. C. All right, so let's talk a bit about MRI. I know we're over the time limit, but we'll try to go quickly. Do we have a few extra minutes, Maria?
Yes, we have a few more minutes. Go ahead.
Great. Okay, so we're going to talk a bit about in-room MR guidance, just to show you some pictures here between CT and MR to show you superior, much superior soft tissue contrast with MRI. But remember that MRI has great soft tissue contrast, but the spatial integrity is not as good as CT because you have distortions in MRI, right? So CT actually has really much higher spatial integrity, and MR integrity spatially can be problematic, especially at high fields because of distortions. But soft tissue contrast is obviously much higher with MRI. Here's another example from Dan Lowe, my friend at UCLA, showing the major difference with low field onboard MRI, 0.35 Tesla here with the ViewRay. The lumpectomy cavity you can see just beautifully shows up on the left, whereas cone beam CT, you can't see anything with this, right? Virtually. So we have two MR guided systems. We have two ViewRay systems, and we use it routinely for pancreas, livers, you know, hypofractionated types of things, SBRT. It offers online adaptive radiotherapy, real-time tumor imaging and gating, and improved lesion targeting enables reduced margins, improved dosimetry, and dose escalation. Here's that same patient. Here's what you see, how we treat this. So you can see the yellow line being the safety margin. When the tumor exceeds that, the radiation stops. When it's within that safety margin boundary, the beam is on, right? So patient is now obviously in a breath hold position. But you'll see here in a second when the radiation stop, when the give them a break to breathe, how it moves out. So you can see it's a really great surrogate because you can actually see the tumor with MRI, cine imaging. And remember, you don't have to worry about dose with MRI because it's non-ionizing, right? So liver SBRT case, showing you an example here. On the top panel, the colors are hard to see. Sorry about that. I'm not sure what happened there, but essentially you can see a much larger ITV on the top panel versus the bottom panel where you're treating in a breath hold way. And you can see the motion of this liver tumor here, within this safety margin. So when the tumor exceeds the safety margin, the radiation shuts off. We use visualization using a contrast called EOVIS for our liver patients. So liver is given 50 gray in 5 fractions. And, we follow the dose constraints of TG 101, 700 cc less than 21 gray. And we have mean dose and V5 considerations as well. And we can also apply this to partial breast irradiation. And you can see some of the fractionation, so 30 gray in 5 fractions for APBI, right? And then the considerations for normal tissue. But again, very nice localization of the target here. And here's the picture of this in cine mode. You can see that even though you can see movement of the thoracic region of the lungs, the cavity stays relatively constant within the safety margin here. Now, this is a patient for prostate. We treat with hypoflame using 5 fractions, typically about 8 to 9 gray per fraction. And what you can see is these transient changes, gas moves through here, and you're able to stop the radiation because the target moved outside the safety margin. So you can actually monitor these things in real time. So just a quick word about online adaptive radiotherapy using this technology. We do some imaging this is all while the patient's on the table. Imaging, recontouring, predicting dose, looking at dose on image of the day, re-optimizing, doing the plan QA and motion verification and treatment. And we do this routinely for pancreatic cancer patients and liver patients. This takes about an hour. It can be 45 minutes to an hour to treat these patients. Here's an example of a reason to adapt. Small bowel is out of tolerance. You see the simulation on the left and the day of treatment on the right. You can see the changing anatomy here, right? So this is the initial plan mapped onto the treatment of the day, right? And you can see there's your small bowel, and we want to keep that to 33 gray line outside of this, right? And if you look now at the treatment day anatomy, you can see the 33 gray line impinging on it. Here's the position of it at the time of planning. So we were able to plan for it there. But because we can re-optimize on the treatment day, you can still carve around that 33 gray line quite nicely here. That's the purpose, right? You want to keep your tolerance doses within check. So when you're doing 10 times 5 pancreas, you have to worry about normal tissues first. And so you can see our constraint being you want it to be less than about 1 cm, 0.5 to 1, we accept at treatment time, 0.5 cc less than 33 gray. But you can see for the duodenum, you're at 1.85, so you exceeded that on the predicted dose, meaning on the anatomy of the day. If you re-optimize, you get down to 0.7. Same thing for the colon. You're at 10.9 on the anatomy of the day, but when you re-optimize, you get down to 0.6. So it's very nice.
We have a few questions about the MR guided treatment for you, Dr. Chetty. So one of them is that if you take into consideration any change for the PTV and for the dose calculation, if you're going to do an MR based treatment. And the other question that we have is if it increases the overall treatment and if it takes too long to do this kind of treatment.
Yeah, so with regard to the first question, it's a great question. I think a lot of that is dependent on the physician preferences. With pancreas tumors, we don't change the initial target.
Okay.
So we map the initial target from planning CT. We map it in a rigid way onto the anatomy of the day. The normal tissues are deformed, but the target itself is mapped. So we keep that target rigid. He does not change his target margins for the 5 fraction pancreas.
Okay.
Now, other sites, like you might have, if you're doing conventional lung cases, with MR guidance, then you will see some changes in a conventional way over, 2 to 3 weeks. But generally with SBRT, you're not seeing a lot of change in the 5-fraction regimen, right? Because it's usually a week or something, a week and a half. So we don't make changes in SBRT typically for targets. With regard to the second question, the time, yes, the time is a factor. So there's been a couple of publications, one that we just put out on looking at the time for adaptation. So meaning in that 40 minutes that the patient's on table, from the time that you start the adaptation till the time you treat, is there any change in the anatomy? And what we found was the paper out of Memorial Sloan Kettering showed actually it wasn't significant. They looked at 10 or 15 pancreas patients on their Unity system, and they found that they did imaging at multiple time points. So imaging right at the start, right before treatment, and then right after treatment. And they found there was very little clinical effect on the actual changing anatomy. And we found the same result. So even though the patient's on the treatment table for an hour, the main issue becomes, can the patient tolerate being an hour? But in terms of dosimetry, it doesn't really make much difference.
Okay, great. Thank you.
Sure. Okay, final question. Which of the following statements is false? A, the soft tissue contrast of MRI is better than that of CT. B, the spatial integrity of MRI is worse than that of CT. C, MRI cannot be used for real-time cine imaging because of ionizing imaging dose. D, CT is an ionizing radiation imaging modality, and imaging dose can be of concern.
So
E, none of the above.
None of the above. Great. So this is the last question. I know some of you had problems seeing the simple question. So if you want to go ahead and you don't see the simple question, you can put your answer on the chat and we will see them too.
And again, you're asking which is false, right?
So yes, to the participants, the ones that are seeing the simple question, go ahead and answer on the simple option. Otherwise, you can put your answer on the chat and that will be okay too. Okay, so almost half of the participants have answered on the Zoom option. I will wait a few more seconds and then we will share the results. Okay, great. Dr. Chetty, can you see the answers?
Yep.
Okay.
Yep. So great. Most of you got this. The answer is C. It's false. MRI cannot be used for real-time cine imaging because of ionizing imaging dose. That's not true. MRI is not an ionizing modality, so dose is not of concern at all. Now, what can be of concern is heating. If you're doing a lot of MR cine imaging, especially with a high field setup, you can have patient heating, and you have to be cognizant of that. But we've never encountered that in the low field setting. You don't get close to the SAR, specific absorption rate heating ratios, so we don't have to worry about that. So yeah, it's fairly straightforward. See, the rest of the answers are all true. So with that, I can go to the final slide here and talk about the main points of this lecture. And so hypofractionated treatments using SRS and SABR, SABR or SBRT techniques require high levels of accuracy in simulation, planning, treatment, and delivery. Localization accuracy is critical. Margin design must incorporate systematic and random errors, as well as other factors such as strength of surrogate. You want to increase your margins when you're unsure about where the tumor is going to be. So Van Herk formalism is available. And advances in technology, planning, and image guidance have enabled us to offer very high BEDs to tumors safely, resulting in better outcomes for patients. So with that, I'd like to thank my colleagues that helped me with these slides. And yeah, thank you for your attention.
Okay, great. Dr. Chetty, if you want to open your camera and I think we can have a few more minutes of questions before 9:30. Because we have other questions on the chat that I think we can go through if you want to open your camera. It was a great presentation. Thank you so much.
Thank you.
So we had a previous question. When you show the index for conformity, it was the question was that if you have multiple targets and you decide you're going to do an SBRT treatment on multiple sites and you have multiple, yes, PTVs or tumor volumes, does that change when you go ahead and look for the index of conformity?
Yes. Yeah. I mean, if you're doing single ISO multiple target, yeah, I mean, clearly you're going to have some differences there in the, your overlap dose and potentially your normal tissue dose. But we have very good guidelines on those types of things anyway, right? I mean, there are overall guidelines on safety for dose for the brainstem and other regions, eloquent regions in the brain. If you're talking about brain single ISO multi-target, there are lots of guidance documents on that, including the task group reports and RTOG, NRG reports on what to keep the dose levels to for single ISO multiple target. Yeah, I mean, it's different than doing planning of each of those separately. Yeah.
Okay, yes, because I think that's something sometimes that happens and you encounter those situations, clinical practice, that you have two different tumor nodules. I mean, on the lung, you can have multiple nodules. You're going to treat two at the same time. So I think that's something that really comes up. But if you have like, any recommendation on any document, we can share that too. With
I do. We wrote a white paper in the NRG, RTOG. I was involved with that on how to manage, in cases where you have multiple lesions you're trying to treat, either with single ISO or, it becomes tricky if you're trying to do this in the thorax and other areas, because you have a lot of motion and there's some geometric issues when you're doing this, one ISO center and looking at multiple tumors, let's say 2 or 3 at different distances from the ISO center. The further away from the ISO center, the further your uncertainty will be, right? Just from the geometry. So there's recommendations. I think they say to keep it within 5 cm, especially if you're doing this type of thing in the thorax when there's motion.
Okay.
But you have to be very careful about imaging and being able to treat those individual lesions because you can have high uncertainties.
Sure. And thank you for sharing all these options we now have for doing IGRT. And one of the questions we had from the participants, and I think that we have both people that use Elekta and Varian, and that's normal. But one of the questions was about the use of symmetry from Elekta in SBRT. So what are your thoughts on that tool?
So the sim to treat, is that what you're talking about? Yeah. So, I mean, look, you're seeing these newer technologies now, like the Elekta machines, but also the Varian Ethos machine, right? Where you can start doing daily adaptive, right? And so it's a similar concept. You're being able to image and treat, within a reduced time frame. With the one I'm familiar with is Ethos, where you don't even need a simulation. You can pull in, let's say, a diagnostic scan or something from another time point that the patient had previously. You can bring that into your planning system, make a general plan for that anatomy that may have been, few months or a few weeks prior to the treatment time, generate a plan, and then bring the patient to the treatment room on the first day, take a set of cone beam images, and then replan on the fly, right? So I think, for a physicist, it's important that all those steps get validated and properly commissioned from a safety perspective. But the technology is now available to do that.
Yes, and I think that every time we're going to see more and more things to come, because that's what's next about radiation oncology. I think it's going to be optimize those technologies.
Yeah, and simless environment potentially. I think where you're bypassing the sim, using previous images, and then bring the patient on day one and doing the actual simulation and treatment at that time.
So yeah, there was another question about when you're going to make a treatment planning, if you decide not to optimize the air volumes. I think this was mostly thought for a long SBRT treatment, where if you have to use the tool that you choose for treatment planning, not to optimize the air volumes. I don't know if you have a thought on that.
Yeah, that's a great question. And yeah, I assume you're talking about the context of daily adaptives, where you have the MR, in the background, and you have the planning CT in the background, the fused MR planning CT, and the volume, the amount of air changes from day to day if you're doing thorax or you're doing GI. Yes, so what we do is we account for the air every day.
Yeah, okay.
We contour, and we've come up with an automated contouring tool for that. So it's much more efficient than actually going and contouring all of the air pockets. It's not a major issue, I would say, we do this most often in liver and pancreas. So you don't see a ton of, air in there, but we do account for it. Whenever there are air pockets, we go in and account for it on a daily basis, because the low density air can have the impact of changing the dose, right? So you want to be able to account for that on a daily basis.
Okay,
But
great.
there's different mindsets on that. I don't think there's been a definitive study showing, major impact of air versus not, let's say.
Okay, great. So yes, so I think we have time for one last question I see here in the chat. So if you have any experience for SBRT for nodal boosts, so if you have like a whole pelvic treatment, if you decide to do a boost, integrated boost, I think for the pelvic lymph nodes that are positive on a PET imaging, or that you think are suspicious for nodal involvement. So
yeah, so I think that, well, we certainly, we have started doing those types of patients following the hypoflame trial from the Netherlands.
yes.
So they published the hypoflame, as you know, which they went up to, I think 8 or 9 times 5 for the simultaneous treatment with integrated nodes. So you can do that. We started doing those patients on the ViewRay, because you can see very nicely how to localize on a daily basis. We do those in 5 fraction, but we're getting a second ethos machine, and we're planning on starting that on the CT based with the new panel. The new imaging panel with ethos is HyperSight, and we feel it's going to be able to give us much better image quality. So we'll start using it there as well.
Thank you so much. It was an amazing lecture.